will be speaking on tropical radiology in Indian context. And actually this is the keynote address in the name of Dr. Harnam Singh Midterm Continuous Medical Education Program conducted by Indian College of Radiology and Imaging, AP chapter of IRIA and KREST. First of all, we have to know what tropical zone is. That is the zone, the geographical area between the imaginary lines. There are no definite lines of Tropic of Cancer in the north and Tropic of Capricorn in the south of the equator. Equator, take it as a middle. And up is the Tropic of Cancer and south is the Tropic of Capricorn. In between is the tropical zone. And tropical belt, more than 36% of Earth's land area is tropical belt. 30% of world population and more than that live here. That's the importance of a tropical belt. More than 1 billion people, mostly vegetarians. And the average calorie intake is low, about 2,100. Most of these diseases are preventable and treatable also and arise from a complex of geographical, biological, social and cultural factors. Most of these are worldwide, not just restricted to the tropical belt, they are worldwide distributions, but some of them are influenced by tropical conditions. That's why it is tropical medicine and radiology. 40 million people suffer from echinococcus, so-called hydatitis. 1/4 of the world's population harbor ascaris, roundworms. 200 million have schistosomiasis, bilharziasis. Untold millions have an exotic variety of tropical diseases which are not confined to tropics, but encountered all over the globe in immigrants carried by travelers. Some of the disorders flourish in non-tropical areas also. The reference by Palmer et al. Now we come to the tropical infections of bones. Viral, bacterial, mycobacterial, cestose, spirochetes and fungi. Viral, smallpox, there is no more smallpox, but what we see is the effects of post-smallpox. Say about 1960s and 70s, there is a smallpox epidemic. Survivors of those manifest with osteoarticular lesions, and occasionally we may see them. Rubella, maternal rubella, about 40% of them children may show certain changes. Polio is almost eradicated, but polio produces muscular atrophy, resulting in deformities of the bones. Bacteria, typhoid, very rare, but still occasionally you can find typhoid osteomyelitis, salmonella, particularly in sickle cell disorders, fusiform bacillus, mycobacteria, tuberculosis is still common. Atypical mycobacterium is rare, but still in AIDS you may see. Leprosy bacillus, leprosy is still not eradicated. Cestose, cysticercosis, echinococcus, spirochetes, Treponema pertenue, producing syphilis, Treponema pallidum, and Vincent fusos spirochete, and actinomycosis and fungi are the other organisms. Among spirochete organisms, Treponema pertenue, Treponema pallidum, Vincent fusos spirochetes producing ulcers are the most common things. Amongst fungi, almost from actinomycosis, nocardiosis, sporotrichosis, blastomycosis, coccidiomycosis. Histoplasmosis is not so rare in India, but that also occasionally you may see. Amongst viral infections, already I have shown you the smallpox has been eradicated, and polio also will soon be eradicated. Notice the smallpox lesions, osteoarticular lesions in the elbow and in the knee. Deformed joints. There is no particular destruction, but deformed, enlarged head of the radius and ulna, and mild dislocations are also seen. These are all results of post-smallpox, previous smallpox. And survivors are very few. Occasionally we come across such patients. As I said earlier, polio, it is, you get deformities of the feet and legs, with atrophy of the muscles, and bones become osteoporotic. Bacteria, gram-positive and negative bacteria, typhoid bacillus, salmonella, fusiform bacillus. See, we are talking about the infections of bones. How does infection of the bone reflect? Pathologically, it is first of all hyperemia, and then lysis of the bone, reparative new bone, simultaneously, ultimately healed. And radiologically, osteolysis. In the beginning, a little bit of osteoporosis and then moth-eaten appearance, and depending upon the virulence of the organism and immunity of the host, resistance of the host, the response differs. Osteosclerosis is the reparative new bone. Simultaneously, even without treatment, the bone responds and osteosclerosis and periosteal reaction may be seen. And both of them may be mixed. For example, in tuberculosis, more osteolysis. In pyogenic organisms of osteomyelitis, more of sclerosis. Periosteum of tubular bones plays a major role. Periosteum normally is not visible, and periosteum is loose in the tubular bones, particularly in children. Whereas in flat bones, the periosteum is incorporated in close contact with the cortex. Same thing with cuboidal bones also, such as corpus and tarsus. That's why periosteal reaction is rarely seen in the cuboidal bones and less seen in flat bones. More importantly, it is prevalent. Any stimulus, not necessarily infection, trauma, hemorrhage, metabolic disorders, all these can produce periosteal reaction. And bone infection is what we call osteomyelitis. First there is marrow is involved, and then the bone is involved. And then it could be exogenous, say a wound, and then infection can get into it, and or it is endogenous or hematogenous also. See, some septic focus is there, for example, tonsil or somewhere else, and because of the bacteremia, these may lodge in one of the bones. Now let us see acute osteomyelitis. And day 1 to 3, you find localized deep focal swelling. We are talking about the conventional radiology. Days 3 and 4, ill-defined extensive swelling and edema, wide subcutaneous planes. The planes are wide, and deep cellulitis. 8 to 12, soft tissue changes not characteristic. Delicate, linear, that too unilaminar type of periosteal reaction, localized permeative osteoporosis, in some extensive destruction by 12th day. In other words, in order to diagnose definitely osteomyelitis, it requires at least 10 days for conventional radiological diagnosis. On the other hand, ultrasonography can detect edema, hemorrhage, periosteal elevation early on than conventional radiology. One on your left is acute osteomyelitis of the distal phalanx of the thumb. Look at the osteolysis and permeative type of osteolysis as well as extensive type of osteolysis, but there is no periosteal reaction yet. As I said earlier, periosteal reaction depends upon the virulence of the organism. Supposing the organism is low virulent, and then periosteal response will be more. Or, if the patient's resistance is more, periosteal reaction comes early on. And then one on your right side is the stump of an amputated, above the knee amputation, and see the moth-eaten appearance, and also irregularity and ill-defined margins of the cortex of the femur. This is acute osteomyelitis. Subacute osteomyelitis, there are morphologically 3 varieties. One, type 1, periosteal reaction may be absent, even subacute. Well-defined destruction surrounded by new bone, shell of new bone, that is Brody's abscess. Brody's abscess is localized infection in subacute osteomyelitis. It may lead to chronic osteomyelitis, but Brody's abscess means localized abscess of the bone. Type 2, periosteal reaction is thicker than in acute osteomyelitis, more diffuse, mottled permeative destruction, often with surrounding new bone and cortical thickening. Already reparative bone is taking place. For example, look at this. One on your left side, lytic areas in the metaphysis of the tibia. Reactive sclerosis is noted both in the epiphysis as well as the metaphysis, but periosteal reaction is not prominent. In old fracture, healed fracture of the both bones of the leg on your right side, they are already healed, callus is noted, but there is infection. Serpiginous type of osteolysis with cortical thickening is one form of subacute osteomyelitis. There is no sequestrum yet. This is what we are talking about, Brody's abscess. Midshaft, lucent area, oval or round, depends upon the type of bone, and then reactive sclerosis surrounding it, and cortical thickening because of the periosteal reaction. Now we come to chronic osteomyelitis. Chronic osteomyelitis, dense cloaking of periosteal new bone. There may be evidence of old fracture or deformity. Bizarre cortical thickening. In the sense, it is not a smooth cortical thickening. Sequestrum, a piece of dead bone is present, which appears radiographically as a dense piece of bone, and surrounding it there is an involucrum formation, which is a reactive new bone from the host. Sinus-stat formation may also be noted. One on your left, chronic osteomyelitis of the calcaneum. There is a heel ulcer. It didn't heal properly and went on to chronic osteomyelitis. Reactive new bone formation, irregular cortical thickening, and some few lucencies are there. Generally, you think of a fungal type of osteomyelitis, depending upon the history, because barefooted individuals often get fungal infection. Otherwise, in bed sores, for example, patient lying down for a long time, from bed sore, osteomyelitis can occur. Or a trauma or thorn prick can induce osteomyelitis of the calcaneum and bones of the feet. One on your right side, chronic osteomyelitis, diffuse cortical thickening, and in the center you find a small piece of dead bone, which may be identified mostly with, say for example, CT. Bare feet infection from soil, you can get chronic fungal infection. Diabetic foot with osteomyelitis is very, very important. Even without osteomyelitis, you can get changes in the bones of the feet because of the neuropathy, lack of sensitivity, added trauma. But with infection, you get osteomyelitis, diffuse thickening, sequestrations, joint involvement, and this is a form of chronic osteomyelitis and diabetic foot. Another chronic osteomyelitis of the tibia in a child with deformity, thickening, cortical thickening, and embedded periosteal reaction. What are the various complications of bone infection, particularly osteomyelitis? Growth disturbances, because it occurs in the metaphysis. Because of the vascular loops, the bacterial emboli are largely there, and this is where osteomyelitis starts. That's why growth disturbances involving the physis and epiphysis. Fractures, pathological fractures can occur. Osteonecrosis, particularly in the hip, for example, if there is an infection of the bone, the head of the femur may get osteonecrosed. Deformities, as we said earlier, malignancy, rarely in a chronic osteomyelitis. From the sinus, you get a squamous cell carcinoma, or from the bone, an osteosarcoma also. And ultimately, in chronic osteomyelitis, amyloidosis. Of course, with the advent of antibiotics, today we don't see much of malignancy or amyloidosis. Specific to tropical countries, particularly India, where in rural areas snakes are prevalent in parks and fields, you get osteomyelitis, not because the snake bite, but at the snake bite there is a tradition that the attender or the relative or the person nearby tries to suck out the wound and spit it out. In sucking the wound, he infects the wound. That's how you get osteomyelitis. This is the osteomyelitis of the proximal phalanx of the thumb. It is already chronic. See, because he couldn't get early on antibiotic therapy, they are treated with all sorts of things, and then sequester formation, diffuse soft tissue swelling is noted. Now, the most common thing is, in India particularly, or in tropical countries, is tuberculosis of the bone. Maybe unifocal or multifocal, unusual distribution, rare sites, atypical bone reaction, occasionally we have seen a dense ivory vertebra due to tuberculosis. It is rare. And then large abscess, huge abscess, only the bone is very minimally involved. Lack of involvement of disc and spinal tibia. As I told you, an ivory vertebra without involving the cartilage in the joint. Multifocal tuberculosis. In fact, the one on your left side, when somebody saw outside, they thought it was lymphoma or metastasis. Patient is young, 32 years old, rare for metastasis, possible for lymphoma. And then MRI showed not only these lesions, but also abscess, adjacent abscess. So we know it must be tuberculosis. That's how we differentiate between lymphoma and tuberculosis. MRI, what is the advantage? Well, of course, there is no radiation. And then in one sitting, we can get multiple views in order to not shifting the patient. Multiple lesions because marrow extension, high sensitivity for marrow lesions, even better than radionuclide scanning sometimes. Soft tissues, nicely outlined, and spinal canal contents. Supposing there is an impending paraplegia, then you know how much of the soft tissue is trying to compress the spinal cord. And then another atypical. See, actually tuberculosis of the bones can involve any bone from head to toe. We have seen skull lesions, we have seen the toe lesions, for example, one on your right side, lytic lesion, expansion, and then soft tissue swelling. Not much of bone reaction. That is what I'm trying to stress. In order to differentiate between septic or bacterial type of osteomyelitis and tuberculosis is bone reaction is much less, except in highly atypical cases. Tuberculosis of the hands, this is so-called sickle cell dactylitis. Sometimes you get a pinna ventosa, ballooning of the phalanx. And cystic type of tuberculosis, less periosteal reaction because in infants and children, there is not much of host resistance. Non-tuberculous mycobacteria, there are 3 or 4 varieties, Mycobacterium avium, intracellular disseminated infection, these are also, but skeletal involvement, lung involvement we have seen, but skeletal involvement